So we're going to be talking about what matters, in particular, interprofessional collaboration to enhance wellness through functional activities. I would like to give credit to the contributing authors whom I'm serving with on a grant, which I'll be talking about in a little bit. And it is an interprofessional team. So it doesn't really want to advance that way. There we go. So this presentation was supported in part by the Geriatric Workforce Enhancement Program from a HRSA grant, in particular a project called the Health Ambassadors Teams for Seniors, which is an interprofessional service learning program that students engage in. And we're in particular going to be focusing on what matters, especially related to functional activities that are meaningful or needed, which help provide guidance for prioritizing goals in healthcare planning. The objectives are that we're going to be focusing on assessment, therapeutic communication, and interprofessional interventions. So the 4Ms is an age-friendly health systems framework developed by the Institute for Healthcare Improvement. And primarily it focuses on what matters, medication, mentation, and mobility. And it's those 4 elements that really promote age-friendly healthcare. What matters is really important because it helps to prioritize the health goals of an individual, and it really targets functional activities. And then once we have those priorities, we can align the healthcare plan with those goals and help people feel understood and make sure that we understand what their preferences are, and also make sure those preferences are documented. So as I mentioned, I'm proposing that what matters really is central to the 4Ms, and I'll show you this throughout this presentation, but it really serves as their preferences for their values, their activities, their tasks, everything that they do, and it can also guide overall care and end-of-life care and decision-making. So why is it so important? Well, what matters really serves as their primary motivation. We use their priorities as overarching motivators for all the other 4M or other 3Ms. So for example, if Henry, for example, really wants to be able to take care of his grandchildren more than anything else, then he will more likely follow through on medication management and his mobility activities for physical activity and participation in cognitive activities, because he knows that he's going to maintain his health in order to keep providing care to his grandchildren. The What Matters also supports that interprofessional collaboration, but by including the patient or the client as the primary team member. And sometimes we do forget that in interprofessional teams. So it really keeps the patient central. I'm checking if I'm checking chats. So in case you want to jump in, just go ahead and jump in, because I'm not very good at going through the material and checking chat at the same time. So feel free, if you have anything to add, jump in. So here are some examples of patient priorities and their engagement. Tinetti, remember Mary Tinetti in the Tinetti balance scale? She and her colleagues created a manual for asking what matters and finding out what matters. And the question that they proposed was, deep down, what matters to you the most? And that's in their manual that you can access. So the examples that are included in this manual really revolve around doing and functional activities, occupations, or tasks, whatever you want to call them from your discipline. But we know that what matters usually involves meaningful activities, occupations, tasks. It involves socializing with people they care about or within the community. It may involve productivity, work, volunteerism. For example, somebody might be motivated to follow through on all of their healthcare recommendations because it helps them stay mobile and alert and healthy in order to keep volunteering at the Senior Citizen Center or to keep volunteering at the Humane Shelter for animals. And it could also be about their own health promotion activities. They can be what matters the most. I just want to keep mobile because I want to keep doing things. Or it might be about self-care or ADLs or IADLs. Somebody might say, I just want to stay in my own home. And I know that if I stay in my own home, I have to be able to take care of myself and my home. And so that might be the most important thing for them as a motivational source. Or it could be caregiving for others. Somebody might say, I'll do anything you tell me and recommend for health maintenance as long as it helps me to keep giving care to my loved one or spouse who has Alzheimer's disease, for example. My spouse needs me. And so I'll do whatever I need to do as long as I can as long as it helps me to keep taking care of my spouse. Or as I mentioned earlier, it might just be engagement in community and going to community events. So this is why it's so important to identify what matters. The other aspect that's really important to identify what matters has to do with adherence. Motivation that I mentioned associated with what matters helps with that adherence. And I'm here today to assert very strongly and boldly that the words compliance and non-compliance are very bad words. And I know most of us have used those. And so I'm really hoping to also change the language, because compliance or non-compliance suggests authoritarianism of healthcare, which is a hierarchy. And we really need to work as a team and keep that client as the ultimate authority, not the healthcare entity. So I'm really hoping that we can replace the words compliance or non-compliance with the words adherence or ability to follow through. When we use the word adherence or ability to follow through, it's much more collaborative and it encourages an open dialogue to identify barriers and strategies or supports that help override the barriers to the healthcare plan and recommendations. So let's use adherence or ability to follow through. And this directly ties into our assessment. So for comprehensive assessment with older adults, to really find out what matters and to use the whole 4Ms, I do like the Ecology of Human Performance model by Winnie Dunn. It's a really good model that is designed for interprofessional teams, and it guides comprehensive assessment that enhances the person's overall range of performance for their engagement in what matters to them, because it addresses the person and all those tasks or activities, and it looks at the natural environment and how each environment influences a person's ability to do those things. So there again, it prompts us to really look at the barriers and supports that influence a person's engagement. So for assessment, we like to create several what matters questions within a 4Ms framework. And with the EHP, the personal aspects might be about things like language, their culture, their preferences, their abilities or limitations. It might even involve literacy, and there's all kinds of different literacy things that we need to consider, like health literacy, reading literacy, even information systems and technology literacy is affected in healthcare. So if we find out that personal information, we can help them better overcome any barriers to being able to follow through on healthcare plans. The EHP model also helps us with identifying specific activities or tasks that are most meaningful, as I mentioned earlier, but I'd also like to highlight leisure. Leisure is a great source for health promoting strategies because we can use their leisure's activities very therapeutically to stimulate cognitive exercise and physical activity just by the way we modify the leisure. But the key aspect of leisure is it's associated with enjoyment, and enjoyment equals engagement. So the more we can find out about their leisure skills, we can actually use that to promote cognitive physical exercise, even to help regulate medications, because people want to be alert in order to do their leisure. And I have a case example that I'll be showing in just a few minutes. And the EHP also looks at the environment or context that the person does these things in. So it could be the physical environment, like their home, could be their social environment. Maybe they have a lot of supports in the neighborhood who can help with engagement, or maybe they're lacking the social support, and we can help to get them connected socially with different social supports. So we did different strategies for assessing what matters to a person. My question to you folks is, how many of you have experienced a client or a patient who was hesitant to tell you what was most important or what was needed? How many of you have seen that? And you kind of wonder what is making them be hesitant to share. You can actually do a reaction button on your on your bottom right. It says reactions. You can click thumbs up or something like that. How many of you had clients who just didn't quite want to tell you something and you didn't know why? Kayla, thank you. You've seen that. So I'm curious what strategies worked well for you to figure out what their hesitancy was. What kind of strategies have you used or tools that help you find out what their hesitancy is? Any suggestions? You can type in the chat box too if you want. Open communication. Yep, that's exactly what I'm going to be talking about. Thank you, Lori. So I give the example when I was a newer graduate, I did a lot of home evaluations, as I did throughout my career, but I really like home evaluations because I can really use that EHP model I was just talking about by looking at the person doing their normal activities in their natural environment and see how all three interact to support or inhibit their actual engagement. So home evals are a great opportunity. But initially, when I would bring this up to some residents, like I worked in the long-term care and their goal was to go home. And so I thought, oh, that's great. Let's go do a home visit or home evaluation before you go home and we can fix any kinks. So I would go up to the person and say, okay, how about normally we do a home eval. How would you like me to go home with you and do a home eval before you go home? And some of the residents would kind of put their hand over their mouth and they kind of look down and shake their head and they go, no, I don't think so. And I thought, no, I was kind of taken aback because I thought, no, well, why wouldn't they want to do a home eval? I was really kind of wondering, Josie, are you wanting to step in here right now?
Oh, no, please share your story.
Okay.
Please can finish.
Okay. And so I thought, well, then it kind of dawned on me and I figured it out. Do you folks, how many of you like to be evaluated? Nod, shake your head. No, nobody likes to be evaluated. But here's the thing, I figured it out. They didn't want me to evaluate them in their home because they were afraid I might disrupt their plans to go home. They didn't want me to go do the home eval because I might tell them they can't go home. And then once I figured that out, I learned a way around that. And so then from then on, I would ask them, okay, so what is your goal, right? What matters? What is your goal? What do you want more than anything? And the person in the long-term goal says, I want to go home. Okay, if that's your goal, I'm the person that's going to help you get there, and I'm the person that's going to help you stay there. And from then on, and then I tell them, then I often do that by doing a home visit with you before you go home so we can make things safer and figure out strategies that will help you go home and stay home indefinitely. And from then on, as soon as I changed my communication just slightly, just like you said, Josie, as soon as I started changing that communication, I never had anybody deny a home eval thereafter. Now, Josephine, you want to join in?
Well, I guess I was just thinking that when I work with clients that are hesitant to share what's really, I mean, it often takes building some trust. So sometimes it doesn't always reveal at that initial evaluation point. But I find with older adults in general, especially if you're in those initial onset stages of potential dementia, there's a lot of wanting to cover. There's a lot of wanting to cover that, or to, like, for example, I had a client a couple months ago whose time awareness was disappearing, and that was very disorienting. So couldn't transition to meal times, and it was just sort of an embarrassing thing, and it took a while to get there and things like that. So I guess I just wanted to add the cognition piece.
That is so true. Some people are hesitant to tell you things because they're insecure about their cognition and their ability to communicate clearly to you. So yeah, that's a very good point. And Dr. Jurevich added, if I ask my patients what they look forward to when they wake up and they say breakfast, I know we have an issue with what matters. And you know what, Dr. Jurevich, we have, and you know this, we have great assessment tools that can really help them identify some interests. We have a nice interest checklist by Gary Kielhoffner that can really help give them some direction about what their interests are, something that will give them motivation to engage in activities that really contribute to their quality of life. So anyway, my main switch then was, instead of calling it a home evaluation, I call it a home visit, and I ask them what their goal is first. And then I center whatever I do around that goal to go home. And by doing that, it really helps to identify those barriers through skilled communication. So for assessing, there are interactive strategies to use for communication that help overcome barriers. And I think most of us have heard about motivational interviewing by Rolnick and Miller. It's from the psychology field and has very useful communication strategies that we'll be talking about in just on the next slide. And then there's active listening, which I'm going to be merging with, but I wanted to separate it here because Mary Tinetti and her colleagues created that manual that really implements active listening strategies to help identify what matters. So that's a very helpful manual too, if you want to access that. And then thirdly, I really like the intentional relationship model. Renee Taylor has very specific strategies, interactive reasoning strategies to navigate some of the challenges that you might encounter with older adults in particular, but she uses it with most all populations. So when combining motivational interviewing with some of the active listening strategies, I'm oversimplifying this, but I'm doing it just to highlight things that are absolutely the most important thing. They both align with what matters because they're person-centered and they're goal-directed. So motivational interviewing and active listening are both person-centered and goal-directed, which leads to positive changes. And in a nutshell, the strategies, and anybody from social work or counseling, please join in and share your expertise. But in a nutshell, I always start my questions with how or what, or could you please describe to me? And I never, ever, ever ask why questions. I never start a question with why, because it can trigger defense mechanisms and put up a wall between the client and myself. Instead of asking, why is it hard to follow through on the healthcare suggestions or recommendations? Instead, I'll ask, okay, so you're telling me it's hard to follow through. Could you tell me a little bit more about some of the barriers to your, or some of the reasons that it's difficult to follow through? And then we can work through that. And I get so much more information by using those motivational interviewing and active listening strategies. They love it when I paraphrase. Ever since I started using paraphrase and reiteration and reflection, I can build that trust almost instantly with them, and they really like it. They really trust me because they know I heard them. And then I like to practice reflections of feelings behind what they say. How many of you have had a client or a patient say, I just want to die? Put your thumbs up if you have. I just want to die. I know a lot of us have had that. It's very common, especially in long-term care. So, and sometimes it kind of stops you in your tracks, and we might kind of struggle to know how to respond. Those reflection feelings that showcase empathy work wonders. And so I've used that too. It sounds like you're feeling really defeated today. And they go, oh, I sure am. Well, and I'll say, well, what would you like me to know? And then they will open up to me and they trust me. So those reflection statements have been really promising. And once you have that teamwork, once you use this, they know they can trust you. They know you've heard them, and then they work with you and share the information. Now, that comment about I just want to die, that can be very loaded and much more complex than just one little 30-second event. So Renee Taylor has a whole textbook that is about therapeutic use of self and using empathy and intentionality and your interpersonal knowledge. But she also has therapeutic modes that she identifies and describes how to use them properly. So there are 6 modes. The first is empathy, which we can show by making reflective statements. Then there's collaborating mode. That's when we deliberately give them choices. And then there's advocating mode, where we help them identify resources that are self-empowering. Then there's encouraging mode, which gives them hope and motivation. So you might say, well, today is the challenging day, but I have seen you overcome challenges before. So I do believe that you will be able to overcome this challenge today as well. And some people may need that encouraging mode at that moment. Then there's the instructing mode. I had that with, I used that one with a nun who had had a stroke. She was quite mobile, but she had some neglect, one-sided neglect. But I walked in one day and she was perseverating, and she was putting her hands up and repeatedly saying, I'm so bad, I'm so bad, I'm so bad, I'm so bad. The empathy wouldn't work because she was perseverating already on being bad, being bad, being bad. And it was more like a perseveration as a result of the stroke. And I had to go into, she really needed me to go into instructing mode and say, okay, I see you're feeling this way today. How about if we start doing that activity like we did yesterday, and just get working, and you'll start feeling better again. And then she followed right along. She needed me to get into instructing. I got her going on an activity, and then she was fine after that. And then there's problem solving mode. One lady she was an older adult in her 90s, and she was living in a low income housing for older, well, it was all ages. But her one thing she wanted to do, her what matters, was making caramel rolls once a week for her son. But one time she made caramel rolls and spilled, when she was pulling it out of the oven, she spilled the caramel on her arm and got 2nd-degree burns. So we had to use problem solving together to figure out a solution to that particular issue. And so we went right into her apartment with her in the wheelchair with a cold oven. And we practiced and tried all kinds of different strategies. And we finally together did the problem solving, figured out, oh, you turn the oven off, you open up the oven door and you pull the rack out with a hot pad until it's cool. And then later on, once it's cool, she could lift it up out of, and then we used a lighter weight pan. So, you know, there's very intentional ways to use each of these modes, and they work like a charm. And then when we have an interpersonal event, which they are inevitable, she calls them inevitable interpersonal events, she has 6 steps for navigating. Those 6 steps can occur within 20 seconds, or they can occur over a couple days. Just depends on what the interpersonal event is and how you're going to manage it. But that's a really good, useful model for anybody. The intentional relationship model by Renee Taylor is very well written. So we have an example of practical example of assessment for finding out what matters. And actually all 4 M's. So the Health Ambassadors Teams for Seniors, also called the HATS, that's that HRSA grant that I was referring to earlier. The program developers created an interprofessional wellness assessment for students to do with older adults via telehealth with a supervisor or facilitator, faculty member present. So the students ask questions from all the different parts of the assessment to draw out all 4 elements of the 4 M's framework. Okay, so the physical therapy students might have asked about mobility, and occupational therapy students asked about what matters and ADLs. Nursing students asked about medications and some medical background, and medical students asked about health history, etc. And so we also, within that assessment, utilize for what matters the COTS Index of Independence in ADLs. It is a tried and true older screening tool for measuring ADL performance. It's a good one for an interprofessional team, and it can be done within 30 minutes, but you can draw out just different pieces of it. There's a lot of modified versions, and it overall assesses eating, continence, transfers, toileting, dressing, and bathing. And each item is scored. A is independent, or anything from A to G. G is dependent. It's more of a screening tool because there are floor and ceiling limitations, but it's good within an overall wellness assessment. It has good psychometrics with good inter-rater reliability and good predictive ability. It's free and available to anybody. You can just Google it and it'll show up on the internet, and you can use it freely without having to ask for permission. But if you use it for research, you have to ask for permission from the journal, from the original. And I do have the reference slide there if you're interested. So here's a real example, and this is Meet Dottie. I have changed her name, but she was the first person we tried our HATS team wellness assessment with via telehealth technology, and her daughter was present. So we'll call her Dottie with her daughter's permission. She has a history of stroke, and she has multiple challenges related to mobility, mentation, and medication management. So using the principles of motivational interviewing and parts of the IRM, early in the interview, we asked about what matters. So for example, what else would you like us to know about you, and what matters most to you about your health? Or tell us what a good day would be like for you. And then the person can describe the activities and the people and things they do. More towards the middle of the interview, then we ask more specific questions about health determinants, the other 3 M's, so medication and mobility and mentation. We added in the COTS questions and IADL's performance, etc. And then at the very end, we went back again to what matters. And we asked her what she wants to do the most. We were very deliberate. It was so interesting because she instantly brightened up and enthusiastic, said, I like to go for rides. Instantly, the whole team knew that going for rides was the most important thing to her. So here is Dottie going for a ride with her daughter and going for a ride on the water with her loved ones. And you can see how important this is to her. She wants to be able to get out in the world, and she wants to get out and see people. So car rides, going for car rides was central to her motivation to take care of her health and maintain her mobility. We also found out when I got to visit more with her daughter, actually, she likes watching Jeopardy, and she'll work really hard to answer all the questions and watch many, many reruns of Jeopardy. And the other thing she loves is socializing. Dottie loves to visit with people and socializing. So I mentioned that this what matters really needs to be centralized to all of the 4M framework. So here is probably the most important slide on this entire presentation. So we've literally centralized what matters: car rides, Jeopardy, and socializing. And these three things were her primary motivations for mobility, mentation, and medication. So going for car rides, Dottie knew that if she wanted to go for car rides, she had to do her physical activities recommended by her physical therapist, which actually was her daughter. So she knew that she needed to keep mobile in order to be able to get in and out of the house and transfer in and out of the car, to be able to sit in the car upright, midline, and be able to look out the window. So car rides were central, and that motivated her to engage in mobility. Jeopardy was, in fact, her mentation exercise. So why would we give her other mentation exercises when she's already doing it with Jeopardy? So Jeopardy was central to mentation. And then she loved socializing. So how is socializing connected to medication management? Well, interesting. Okay, so she was motivated to manage her medication effectively, because if she didn't manage her medications, she would be too tired during the day to socialize. And so she actually was more intentional and deliberate in managing her medications properly in order to be alert during the day to socialize. So this is what I'm talking about, keeping what matters central to the whole 4M's framework in health promotion. Any questions on this?
I have a sort of like question or just like dilemmas around this that I've kind of run up against that I'm curious to like put forward for conversation potentially. I've since left working at this assisted living facility and like therapy provider, but I've noticed like some trouble getting the interdisciplinary team kind of on the same page with this stuff. For example, one of the circumstances that prompted me to leave was I'm an occupational therapist, by the way. I was working with a client with Parkinson's that had recently progressed, and during my initial assessment, she mentioned that she would like to own a dog again. So I put that I just on the eval that client motivated IADL to own a dog again, and that triggered a lot of controversy. Just that I said that she wanted to have a dog on the team. And there was a lot of tension about whether or not it was appropriate and a lot of different goals. And I guess I've had some challenges getting client centered with the team in terms of who gets to kind of decide those things, where sometimes the client is disempowered. And then second from that, I've also noticed that like with the what matters at the center, often in geriatrics, there's sort of like competition or like this idea that we all have to have separate goals, where I'm seeing from this, it's like, well, we all can kind of support the client on the same goals. And I've heard from somebody too that's been like working with Medicare billing for years that they've never actually gotten a denial from, say, PT and OT and ST kind of having a similar goal. And I guess I was curious if you have any insight on this or guidance on how we can get the interprofessional team kind of on the same page.
So I do have experience with what you're saying, and both parts. So the one part is getting the interprofessional team to work it collaboratively, and the second part is sharing goals. So the first part, what I've done, and I have had instances like that, Josephine, as well, and I actually use therapeutic communication with my team members, and it worked. And it's a clear, simple answer, and I know there are more complications than that, but I got to know my team members and established more rapport, or I ask them questions first, and then I paraphrase and reflect what they're saying, and then they feel heard, and then they take turns to hear other aspects as well. It has worked. It works well with clients. It works well with interprofessional team. That's another whole big topic that could really warrant a lot more discussion, but I'm just giving like the short answer for now. So but then also the reimbursement. So for example, both OT and PT are working on transfers, but OT might be doing standing pivot transfers for toileting, whereas PT might be doing walking transfers so they can get down to meals, for example. So there are some subtle nuances in slight differences in those goals, but I've never been denied a payment for sharing similar goals, but they're never the same goals.
Which what I'm seeing here in like centering what matters, maybe all disciplines and even beyond the therapeutic disciplines, really our shared goal is that they would be engaging in the car rides, the jeopardy, and the socializing as part of their daily routine. And so from that, it seems like it would make sense that that would be incorporated in the plan of care for the entire team, really, and not just, oh, well, I'm working on jeopardy. No, I'm working on jeopardy and stuff. So we have to get to a place where like, no, we're all working on jeopardy because we're all working on the client's goals.
Right. Yeah. So they might be doing some mentation activities and speech language pathology for cognition in order so that she can play jeopardy, or they might be using jeopardy as a therapeutic activity. But yeah, I think there can be overlap and everybody can tap into what matters. So going on to the plan, thank you, Josephine, for adding in. I continue to use the ecology of human performance because really helps us to have a comprehensive plan that about prioritizing those functional activities, and it helps us address the environment, the tasks, and the person. So for example, in addressing the environment, we have a wellness plan packet for the HATS program that students and supervisors can select materials from. And one of the items in this packet is the CDC home fall prevention checklist for older adults. It's free and available to everybody. I only put the first 2 pages in there, but this really helps. You can give them this packet or this checklist and send them home, or give it to a family member to go through the home and assess the environment and make modifications that are listed in this checklist. That really helps to address those environmental issues that could actually compromise their ability to age in place if it's not addressed. So this really does help with safe aging in place. We also include functional activities that we have pictures of people doing different types of functional activity in different areas of their home environment that can tap into functional mobility. And leisure activities are a great meaningful activity that can be used for both cognitive exercise and physical activity. So painting is one example. It helps with focusing, sequencing, attention span, decision making. The painting could be done in standing with rotation across midline and diagonal movements to activate the proprioceptors for knowing where the body is in space to reduce risk of falls. And so really utilize leisure interests, and that engagement in leisure, they love it, they enjoy it. So because of that, you get more repetition, duration, and intensity for motor learning aspects to enhance cognition and mobility, for example. So I really believe in the power of leisure. Now, another example of challenges that we might see from these assessments we do, meal preparation. How many of you have seen people that have weakness due to malnutrition or not eating? And we find out a little bit more information that maybe they're avoiding meal preparation and eating because it's too hard to carry food items while having two hands on a walker. Well, this is where the interprofessional team can really collaborate beautifully. So here's a picture of somebody with a walker set aside, which is an unsafe reaching position. So the primary care physician can do the assessment and can actually refer, if this person's not eating, we need to find out the reason why. So we could have a PT go into the home and assess safe mobility and balance in the kitchen. We have the OT go in and propose adaptive strategies, such as putting a tray on a walker to carry items. We can have nursing and the pharmacist help with coordinating medication with meals. Maybe it's a problem with medication management, and maybe they're losing their appetite for eating, or maybe certain foods, certain medications need to be taken with meals. So they can help with coordinating during meal preparation. A nutritionist may help with the diet. For example, an older gentleman with diabetes whose wife passed away says, I have no idea how to cook, and I don't have no idea what I'm supposed to eat with diabetes because my wife did all of that. So that would be something where that nutritionist can come in this interprofessional team. I personally would love to have all of us in the kitchen with this person at the same time, but that's, two at a time, and then individual meetings works as long as we're all collaborating with each other. And then I really like the role of social workers, all of those community support services like home delivered meal. If all they're getting is that one meal every day, Monday through Friday, I know they're at least getting one balanced meal every day. So I'm a firm believer in that. So here's another picture of the person using the safe walker placement and then reaching, which OT and PT can work with. OT might have recommended a tray table, or this bag might work for some of the things too. But this meal preparation targets, so meal preparation might be what matters, but it targets mentation, mobility, medication, and what matters. It targets all four. And it shows how the IP team can work together. The other aspect of the interprofessional plan for the person's healthcare plan involves personal support through either referrals for skilled services or other types of services, or community resources recommendations. So there might be referrals. We might do the HATS wellness assessment and find out, I think there's something more going on with this person. This person seems really dizzy, unstable, something's going on. And I've done this where I've referred somebody there. Everything improved after the stroke except for balance. Now, why is balance not improving at the same rate of all the others? And then I ask her, well, how's your ear? How does your ear feel? Well, and she says, I actually had an earache last night. Oh, back to the primary care physician, do an assessment, look at the ear. She's got an ear infection. She gets on antibiotics, and all of a sudden the balance is fine again. It's very interesting. So there might be a recommendation or a referral back to the physician for more assessment, or there might be referrals for psychology and counseling. And we really need to address that, by the way, because older adults actually have very high rates of suicide compared to other age populations. And a lot of the suicides some of the stats say 20%, some of them say 50%, around there. The suicides actually occur after their most recent physician visit. So sometimes they get bad news. We may need, if we have to deliver bad news, that person may need to go directly to counseling to help them cope with the bad news. But other skilled services that I mentioned in the prior slide, speech language pathology can really help with those cognitive assessments. We might want home health care support for ADLs, or even just a home companion to have somebody with them periodically. And then we have a list in our packet of community resources. And this one I got in Grand Forks from service providers for seniors. And it has a list of all the different types of services that may benefit older adults to help them really age in place. And it includes things like the home delivered meal, the senior citizen center. Senior rider programs are great because getting out in the community through a senior riding program is really stimulating for their mentation, their mobility, and it also prompts good medication management, because we know that that mobility can also help with blood sugar regulation, for example, and the amount of insulin they need or don't need, or blood sugar levels. And I really like the different fitness center programs that are afforded to older adults in different communities. So our plan includes all of this information, but we can pick and choose from the assessment outcomes whatever might be most meaningful to them. So some of the other recommendations might be more screenings, vaccines, what matters, maybe recommending meaningful activities with the community supports, medication reassessment and alignment, mentation activities, mobility, etc. So going back to Dottie, from that little bit of information I shared, what referrals do you think would have been helpful for Dottie?
Does she live alone, or was she part of a assisted living or something like that? I can't remember.
She was living alone in her own home, and her daughter would stop in daily, but her daughter worked a lot of hours too.
I would consider a non-medical home care agency that could kind of visit and help make sure like the setup of the Jeopardy happens and functions. And
Yep, I agree. The home care, and it's not just about ADLs, is it? It's about home care to help do some of those other activities that support mentation, and how home health care, home meals on wheels. I agree with that. Senior companion program, I agree with that. In-home care programs through aging services, absolutely. And the YMCA for field trips. Yeah, they have such a good program with the adventure group. North Dakota Assistive Senior Safety. Yeah, I really like North Dakota Association for the Disabled to even check out a tub bench for free so that they can do their own hygiene. Yes, those are all important things. All of those things can help. So in summary, what matters can be central to the 4Ms as it addresses meaningful functional activities that really serve to help prioritize the person's goals and support adherence in health promoting strategies. Our interprofessional assessment really is comprehensive, and it really does take a team to do wellness assessments. And then we can use that assessment outcomes for a plan that includes a lot of interprofessional collaboration resources and different referrals. Yes, home safety could be knowledgeable about what the community and the state can offer our older adults. And it all comes back to promoting age.
I'm curious, in North Dakota and how this assessment is usually administered, is that kind of through a home health context, like through PACE programs, or
yeah, well, this one was through a grant. It was a HRSA grant for geriatric workforce enhancement programs in North Dakota. They're really trying to increase the numbers of students who are prepared to work in geriatrics, especially when you see the growing population. And so that one's through a grant, but it's not a whole lot different than what I do with the nursing home and the interprofessional teams that I've worked in there as well, or in the hospital as well when we're playing.
30 years ago, I was in therapeutic recreation, and at that time in a rehabilitation medical environment, and the team approach was used pretty effectively there. It was one central goal, with in that setting. And so every other discipline used their professions and skill set to support that one main goal. But what I see now is the challenge of services within a setting, like assisted living setting maybe, versus home. And since we're trending more to keep people at home longer, how do we economically, and going back to Josephine's stuff, economically, how are we going to meet that challenge of providing services for people who are in homes? Because they're not at a place where there's 60 residents and, they go spend 10 minutes a day with each one of them, whatever for the week. So I just want to throw that out.
Oh, I think that's such a good question. That really is the biggest challenge, is how to be economical. How do you bring a team to a person in their home? But yet our services are more effective when done in the home, in their natural environment, because we can help them navigate through those barriers and strategies to overcome those barriers. So actually, if you look at it, the efficacy is better when you do it in the home. But it's so funny that you bring this up, because there was one idea that just came up yesterday, and it was also recently in the news. There is a program here in town that's doing it's a mobile therapy clinic, and that's for geriatrics. And I also had a discussion yesterday with a pediatric therapist, both PT and OT business, and they want to get a mobile bus. They just went and looked at one yesterday, to provide pediatric therapies to children in their natural environment, because the outcomes are better. You might be able to cut, instead of 12 visits, you have 3 or 4 really good visits in their natural environment. Maybe you make more progress as a team doing those 3 or 4 visits than you would individually doing 12 visits, just because you're doing it in their natural environments and you're bringing the clinic to them. I don't know. It's kind of exciting. I think
we need to coordinate then as an interdisciplinary team with advocacy and payers, in that we need to view it not as competition for resources, but view it as the shared goals of the client and what they want their daily occupations to look like, that as a team. In my state, unfortunately, in home health, we've followed that pattern of deferring, say, OT referrals until the second suite of 30 to 90 days. These payment system changes have really fractured, and the emphasis on productivity. One of the key ingredients on an advocacy standpoint for everybody on the interdisciplinary team is we need to leverage with payers to get acknowledgement for indirect treatment time that allows us to coordinate with the team members, because otherwise corporate rehab providers, agencies aren't going to reimburse therapists to coordinate services. And so I think really we all should band together to advocate for that.
Yep. So I was talking a lot about client barriers to be able to follow through, but what we could really add to this presentation is healthcare providers barriers, especially related to reimbursement.